and what the procedural treatments are, with a focus a little bit more on what's called rezum therapy, which is a newer treatment that was recently FDA approved and is starting to get covered now here in Virginia. So, the prostate. Prostate sits right here, underneath the bladder that's here, on top of the rectum right there, and the urethra travels right through it. So when we talk about the urinary tract, we tend to refer to things as the upper tract, which is the ureters and kidneys over here. The lower tract, we talk about lower urinary tract symptoms. That's the bladder, the prostate, and problems with the urethra where it goes through the penis, or in women, just straight out through to the introitus. So the prostate's a relatively small gland, 10 to 60 grams. Well, what is that? A gram is roughly 30 grams is 1 fluid ounce. So we're looking at things that typical prostate size is about 25 to 30 grams. Usually when we talk about enlargement of the prostate, we're usually talking around 50, 60 grams, but more and more as guys are living longer, I'm seeing 120 grams, I'm seeing 150 grams. The biggest I've ever had was 460 grams, which is, bigger than a can of Coke. The purpose of the prostate. People think that it's an erection organ. It has nothing to do with erections. The sole purpose of the prostate is to make proteins and fluid that is necessary for sperm to survive in the vagina. It is entirely a reproductive organ. Unfortunately, it just happens to be wrapped around the urethra, so over time it can cause problems for people trying to pee. So prostate problems. People can have an enlarged prostate. That's what we'll focus on today. Prostatitis, inflammation of your prostate. Prostate can get infected, and people can very suddenly develop all the symptoms of benign prostate enlargement, but almost instantaneously, sometimes associated with fevers. Then another prostate problem is prostate cancer. Now, some people are unlucky enough to have prostate enlargement, prostatitis, and prostate cancer all at once. Having one or the other, they're not mutually exclusive. And each condition can affect the prostate in different ways, and they're all treated differently. So what is BPH? Benign prostatic hyperplasia. So benign, that says it right from the beginning. It's non-cancerous. It's an enlargement or growth within the prostate that is not cancer. Hyperplasia is just a fancy way of saying a lot of cells. That's the clinical term. It has nothing to do with cancer. When I look back at this slide here, the cancers tend to be in the outer aspect of the prostate, and in the central area of the prostate is where the enlargement tends to occur. It's not a predictor of cancer. If you have the symptoms of BPH, it does not mean cancer. Also, the PSA is not necessarily, which can be a predictor of cancer, can be a predictor of BPH, but it's not necessarily an indicator of BPH. So when we order a PSA test, we're screening for cancer. We're not screening for prostate enlargement. Screening for prostate enlargement really comes down to just an assessment of symptoms. And as the prostate enlarges, it can squeeze the urethra tighter, and people have more difficulties urinating. What's interesting, though, is that the size of the prostate does not necessarily correlate with symptoms. Some people have huge prostates, and the way the prostate grows is it tends to grow outward, and the urethra running through is relatively unencumbered. Also, some people's bladders are a little bit stronger. So, just like some guys have stronger biceps, some guys have stronger bladders. So they may not necessarily have the symptoms if the prostate is growing, as long as the urethra is not encumbered, or as long as the bladder is strong enough to compensate. Some people have tiny prostates, and the little bit that the prostate grows, it squeezes the urethra real tight, and they have troubles peeing. So as I was saying, the cancers tend to be In the outer aspect of the prostate, the benign, non-cancerous enlargement is usually in this central area, squeezing the urethra, making it tougher to pee. I always say, think of drinking a glass of water through a regular straw that you get at McDonald's versus through a coffee stirrer. A more narrow straw, you've got to exert a lot more force to suck the water through. The same thing is happening to the bladder when the prostate is squeezing the urethra. It has to exert a lot more force to get the urine through. This is a picture when I look at a large prostate through a scope that I can do in the office. This is the picture of what that prostate would look like, where the channel, the urethra channel, is very narrowed and compressed. This right here is the right lobe of the prostate squeezing in. This is the left side of the prostate squeezing in. Again, difficult to pee through a very compressed channel. So symptoms. We call them LUTs, or lower urinary tract symptoms. Some people have all these symptoms. Some people have a few. Some people, they can come on very gradually, and other people, they seem to, a snowballing effect seems to occur, a little bit more quickly. But we tend to see frequent urination. If you're not able to empty your bladder all the way, then it doesn't take very long to fill your bladder back up. And so therefore people can go more frequently. Urgency to urinate. If every time your bladder is peeing, it's having to work real hard to squeeze the urine through the urethra, then the muscle starts to change. The muscle gets thicker. You see bodybuilders walk around with their arms kind of like this because they can't stretch them straight, too muscle bound. If the bladder is getting muscle bound by straining to urinate every time you go, then the muscle starts to thicken and it doesn't hold the urine as well, so you see more urgency to urination. Some people have difficulties getting the stream started. I always say, think if you're trying to push a heavy box across the room. Once you get the momentum going, it's fine. It can just be very difficult to start. And so people may have to initially push or strain or have a slow stream at the beginning of urinating. Some people just have a weak flow all the way throughout. And then a lot of people have troubles controlling their urine when as they're finishing off a lot of dribbles, a lot more time in the toilet. The 15-year-old guy at the urinal next to you gets in and out of the bathroom a lot faster than you may. With prostate cancer, and this is probably the last time I talk about mention prostate cancer here, these are not the symptoms of prostate cancer. For prostate cancer, there really are no symptoms until it's spread, because again, prostate cancer is usually at the outer aspect of the prostate, and the urethra is typically not impacted or affected in any way until a cancer is much more advanced. Half the guys between age 50 and 60 will have some symptoms of BPH. Now, not necessarily to the same degree. Some people are horribly affected and other people not, moderately. But about half the people in their 50s, by the time you get up to age 80, 9 out of 10. So this is a problem of, as we talked about David Warren earlier, if you live long enough, you will have a urologist on your Rolodex. If they still make Rolodexes. It can impact quality of life. So we think of BPH as a health issue in terms of, if you're not emptying your bladder well, you're more prone towards infections, you're more prone towards kidney failure, but it can also just impact your day-to-day state of being. If you're peeing all the time, you really don't want to take flights anywhere, so people avoid travel. Interruption of leisure activities. You may have a friend that you golf with that every 2 holes, you're putting in your last putt and they're kind of off to the side, peeing on the golf course. Afraid to use stalls because it can create some embarrassment in the bathroom where it's just taking a long time to go, wondering if everybody's watching you or listening to you. And then disruption of sleep patterns. If you're waking up 3, 4, 5 times a night, it's hard to get good quality sleep. For some people, and for most people, they tend to be gradual to the point where just like you age, you're like, well, I don't remember myself getting older on a day-by-day basis. Guys get to a point where they really struggle to pee, and they're like, I don't know how I got here. It seemed like not too long ago I was doing fine, and now things are a lot different and a lot worse. For some people, they have initial symptoms, they remain stable, and for others it's a continued progression all the way up to the point where maybe they can't even pee. These days, there are a ton of medicines available and a ton of procedural options available where usually we can pick one where people don't have to suffer if they don't want to. So how do we diagnose it? Obviously, it would be nice if I could just have a quick, easy picture of your prostate and know exactly what was going on in the urethra. But CAT scans and MRIs, they don't really show the prostate all that well, especially when we're looking for just benign enlargement. So we tend to go with a good history and physical, and then we add tests if we need them. But most of the time, I can glean a lot of what I need to know just by talking to somebody and listening to what they tell me. So we can also assess your symptoms with what's called an AUA symptom score. How often are you waking up at night? How would you rate your stream? How well do you empty your bladder? And then we can also, with those scores, it gives a numerical value. We can track somebody's progress a lot of times with how they've responded to treatment. And the most important thing for a lot of these guys is, how bothered are you? Some people have very few symptoms and they're coming in talking to me like it's the end of the world. Other people, I'm like, I don't know how you live every day, and they're like, it's no big deal. So how much somebody's bothered does play a role too. Once we go through a history, physical exam. I'll do a rectal exam. That tells me approximately the size. Again, the size of the prostate does not correlate with symptoms, but the size of the prostate does impact what medicines might work or might not work, and it does lead me to know which procedures somebody might be better suited for. Also, I'm looking for prostate cancer when I do the rectal exam. Another thing we can do very easily in the office, I just put a little ultrasound on the lower abdomen, not invasive, and just see when somebody's done peeing, how well are they emptying their bladder. So when I do the rectal exam, I'm only really able to feel the underside of the prostate. So it's not perfect. I'm not getting the men in this room who've had a rectal exam, you're happy that I'm not able to get my finger completely around the prostate, but I'm only getting a sense for how deep does it go back, and then side to side, how wide is the prostate. And from there, I can kind of estimate the size. This would be a surprise rectal exam. In terms of diagnosing it, once we get through the initial physical, if we decide a treatment plan, if people really aren't still getting better, we can do a little bit more testing. One is a uroflow. In the office, I have a toilet that has a very special sensor, and when you pee, it measures the velocity of how fast the urine is coming out of the bladder, and I get a sense for exactly what the flow rate is. Sometimes we can do a little bit more invasive testing where I actually put a pressure probe inside the bladder, and I can see how much force your bladder is exerting. I don't really have to do this very often in guys. That's more of a thing of the past. Transrectal ultrasound can sometimes give a sense for the size. Usually we don't have to do this when we're just doing the benign enlargement, but occasionally if somebody really wants one type of procedure or another, we'll do an ultrasound of the prostate too. And cystoscopy, where I put a camera right through the urethra and take a look. I numb everything up. It's a small, flexible, not too invasive scope, and it takes about 20 seconds. If BPH is not detected, many guys have no problems at all. They just kind of go through life and they're not impacted. Other people eventually can get to the point where the bladder really starts to change. I talked about a bladder that works hard to pee, the muscle starts to thicken. So if this is a normal bladder here, well, when the prostate is enlarged and the urethra is obstructed, the muscle gets thicker. The striations in the bladder become much more apparent. And the bladder doesn't stretch as well, it doesn't squeeze as well, and the bladder can become almost like porcelain. It doesn't move a whole lot. It's pretty rare. Usually that doesn't just sneak up upon somebody. Usually we catch that happening gradually. It can lead to retention of urine where guys can't pee at all. They find themselves very uncomfortable, and in an emergency room needing a catheter, or in my office needing a catheter. As far as the treatments, that are available. Watchful waiting. You know, for some people, their symptoms aren't too bad, and we can just kind of see how they do. Monitor how well they empty their bladder with that bladder ultrasound. Phytotherapy, herbal medicine. I'll go into each of these things a little bit more. Standard medication, prescription medicine. Heat therapy, microwave or radio frequency ablation. Surgery, the old-fashioned rotor-rooter, the TURP. These days it's a little bit more elegant with a laser. The urolift, which is a new procedure that's been introduced in the last couple of years. And then the rezum, which we'll talk about a little bit more today. They all have, every treatment has its niche. You know, sort of the saying is, you know, people may widely recognize Ferrari as the best car, but if you're living in the mountains of Vermont, maybe that's not the best car for that environment. So, you know, there's a patient where all of these things potentially has a role, but what's good for one patient is not always what's good for the next one. So phytotherapy, herbal medication, the one that people think of the most is saw palmetto. Advantages, well, it's not surgery. You're not having to claim a prescription. No side effects. Well, I don't know. That's the problem with the herbals, is that there have not been a lot of good studies on them. Disadvantages, well, there was a big study done on saw palmetto, randomized, done at a lot of institutions across the country, and everybody was blinded. They didn't know whether they were getting placebo, getting a sugar pill, or getting saw palmetto. There was no difference in the placebo group versus the saw palmetto group. So saw palmetto is a billion-dollar industry, and it's basically been debunked as being no different than taking a Tic Tac every day. But if you believe that that Tic Tac is working, it might work for you in the same way that's the way the placebo effect can work. Potential downsides, well, if somebody has an undertreated prostate, their bladder health or kidney function, stones can develop. Bladder function and kidney function can deteriorate. Standard medicines, prescription medicines, Flomax, Rapaflo, Hytrin, Terazacin, Alfuzacin, Uroxetrol, finasteride, dutasteride, Avodart. These are the medicines that we prescribe. It seems like for a while there, every few years, a new medicine was being invented. Interestingly, we're not seeing that anymore because all these medicines are going generic, or have gone generic, and they're becoming cheap. So we haven't seen a whole lot new come out medicinally. The advantages of medications, well, it's not surgery. So in general, they tend to be reversible. You stop the medicine, any side effects you were having, they go away. People tend to feel comfortable taking a medicine because of that reversibility. And for most patients, the medicines do enough. Downsides, gotta take it every day. If you don't take it every day, you're not gonna get good relief. Some people think that they're becoming like addicted to the medicine, or that their body has grown dependent on the medicine. That really doesn't seem to be the case, but you know, so if somebody stops taking the medicine stops taking their Flomax after they've been on it for 3 years, and then they go into retention and they can't pee, they're like, well, I was dependent on the medicine. Well, probably had they never taken Flomax over those 3 years, they would have gone into retention 3 years later anyway. So it's not necessarily dependence that develops. There are side effects, though. Two of the medicines, finasteride and dutasteride, will lower sex drive and cause problems with erections. All the other medicines will cause some ejaculatory dysfunction. Less semen comes out at time of orgasm. For some people, that's a real big deal. For other people, it's no big deal at all. Some of the medicines will create a little lack of energy because dutasteride and finasteride work by blocking the activation of testosterone. So kind of a lower active testosterone can result in a little less energy, a little decreased mood. We used to see a lot of problems with high out-of-pocket costs. It's less so now as a lot of these medicines are becoming generics. And then over time, the medicines may not just be able to keep up with the growth of the prostate that each individual is getting. Microwave therapy. So this was all the rage about 15 years ago. Office-based procedure, you come into the office, a little catheter gets put in the bladder, and right where the catheter is in the prostate, microwave energy gets dissipated outward, and it, in a sense, creates a kind of a thermal burn. Take the catheter out, takes about an hour, go home the same day, not a lot to it. The long-term studies have shown that there's absolutely no difference between microwave therapy and medications. And when those studies came out and basically proved that, we found ourselves not doing microwaves very much. Why put somebody through a procedure if it's not really going to do the same job that the medicines are going to do? The benefit of microwave therapy, though, was those guys who wanted something done, but they couldn't tolerate the side effects of the medication. They got too dizzy, or it really impacted erectile function, something along those lines. Most people who have microwave, because the medicines weren't working, pretty much every one of them ends up going on to some other treatment. And because of that, I would say microwave's really fallen out of favor in the last 5 or 6 years. TURP, the Roto-Rooter. This is, now the green light laser. These are the gold standards for the optimal treatment of the prostate in terms of what gives the most symptom relief. This, other than any medicine or any procedure, the TURP, or the laser vaporization of the prostate, maximizes the flow and minimizes the obstruction more than anything else. We're actually removing prostate tissue using a laser, just turning it into water vapor and opening up a physical channel right through the middle of the prostate, coring it out. And it's durable. Only about 10% of people need something else done within 10 years after one of these procedures. Half of those because scar tissue can develop, so that's one of the downsides is one of the downsides is 5% of people will get some stricture or scarring in the urethra after the procedure. And the other half, either because we didn't get enough tissue out the first time with the laser, or new tissue grows back over time. The other downsides are, these are hospital procedures, usually under general anesthesia. So in the hospital under general anesthesia, a lot of times more cost, a little bit more risk. I mean, in general, anesthesia risks these days are not terrible for most patients. Certainly if patients have heart conditions or neurological conditions, that may not be the case though. The laser is an outpatient procedure that's as effective as the TURP, the Roto-Rooter transurethral resection. But the TURP very often does require a little bit more bleeding potential and does require a hospitalization in many patients. 1 to 3 days is typical. Usually a catheter for 1 to 5 days. When I do the green light laser, I usually have a catheter in patients for about 36 hours. With the TURP, not the green light, but the TURP, 10% of people have erection problems. Well, I just said earlier in the talk that the prostate is not an erection organ. It's just there for reproduction to make proteins for the sperm. Well, the nerves that control erection sit right on the outside of the prostate. And the electrical energy from the TURP, that electrical energy can get transmitted through the prostate and injure those nerves, creating some problems. Most guys don't have an issue, but 10% do. And studies, I mean, this is kind of a wide range, but this is the range of the studies. 40 to 90% of people will lose their semen, a dry orgasm, and for most of those people, that's forever. It doesn't come back. So if you're not trying to make a baby, it's usually not that big of a deal, but you know, that is one of the downsides. And you know, a lot of guys are like, hey, I've been doing something one way for the last 40 years, and I kind of like it that way. I don't want to make a change. The UroLift. The UroLift is a newer, less invasive way of treating the prostate, kind of compared to the TURP. It can be done in the office. It's better done for most patients in the operating room, but it tends to be pretty quick, only 20, 30 minutes. Better to be done in the operating room or under some sedation because it's kind of uncomfortable for patients. But it can be done in the office if somebody's just too sick to go to the OR. For this one, we're basically putting a camera through your urethra towards the bladder and firing a little gun through the prostate to the outer edge. It's like almost like a little harpoon. You kind of jiggle the end, and the harpoon turns so that it's from perpendicular to the urethra to parallel, and then there's a suture that goes through it, and you just tighten that suture up with another little pledget right here, and it's opening up the prostate kind of in the same way you open up the curtains at your house. Just kind of move it, mechanically move it. And you just open it up. Now, it preserves sexual function, so loss of erections, we don't really see that with this procedure. We don't see that with the laser either, but we do see it with the more old-fashioned TURP. And only about 4% of people have the loss of semen, so that's the real benefit of this procedure. The results in terms of the flow are better than medications, not as good as the TURP, the green light, or the other thing we're going to talk about, the rezum. So this is somewhere in between medications and the other treatments. The downsides, well, you still need a catheter 1 to 3 days. A lot of urologists have tried to get away without doing it, and it's resulted in quite a bit of trips to the emergency room of people unable to pee or having some bleeding. Leaving a catheter in for 1 to 3 days helps. The other downside is it's really only for the small to medium-sized prostates. This just doesn't do the job for the bigger prostates. So it's kind of a more narrowed focus of who's eligible. But I'll tell you, the right patients, it seems to do well. The last thing in here, I put in here as, this is something that concerns me, it's a foreign body in your prostate. There was a thing out there, if anybody's heard of it, done in the late 1990s called a uroloom, which is a stent, which on the surface of things makes a lot of sense. We put stents to unblock somebody's arteries in their hearts all the time. Been doing that for decades with good success. Well, why not just do it for the prostate? Well, the calcium levels in our blood is about 9.5. The calcium levels in your urine are 200. So over time, those stents calcify. The urolift is coated with a substance that eludes calcifications. I just wonder, it's only been out for a few years. How about at 10 years? How about at 6 years? Are there going to be long-term issues? The other thing I always wonder about is there chronic inflammation associated with having the foreign body in there that we know chronic inflammation in the prostate, prostatitis, does have a higher risk of prostate cancer in the future. There's never been an association that's been gleaned in any study between the urolift and prostate cancer, but is it because it hasn't been carried out long enough? These are just questions I've always had, and so I tend to be pretty conservative when adopting some newer technologies if there are some questions, unless that newer technology has a whole lot more advantages that would really outweigh the potential risks in my mind compared to other treatments that are there. So one of my partners really likes the urolift, and I think it's fine in the select patient, but I don't wholly endorse it only because of the questions that it brings up for me. Rezum is supposed to kind of align the benefits that you get with the urolift. Could be done in the office and should be done in the office more often than not. Tends to be pretty quick. Its flow rates are better than urolift, better than medications, not quite as good as the laser or the TURP, but better than the others. And only about 4 or 5% of the people will have the ejaculatory dysfunction. So a lot of the benefits that the urolift has, the rezum has, and to me, because it's not a foreign implant, a foreign body implanted in you, it does have satisfies a lot of the potential concerns I do have about the urolift. They're saying is only a few drops of water. What it is we're basically injecting water vapor into the prostate. And the steam the heat of the steam kills a lot of the prostate cells in a very limited compartment area. It doesn't blast through your body and kill all the cells in your body, just a very limited area within the prostate, and denatures the proteins, and then over time your body reabsorbs those proteins. There's a little video of it here. This is an animation. I was looking at videos of what it really looks like, and it's just like watching, I don't know, like a pin getting pushed into a cushion. There's nothing exciting about it. So a camera goes in, and there's a tool that then gets injected right into the prostate. For 9 seconds, steam gets injected in the prostate, and then you move on to a different spot. And what it's doing is it's killing the cells and denaturing the protein. So it's killed a zone here. We kill all the thing on this side, do it over here, do it right there. Each blip is 9 seconds. So in the office, it's probably about, for most patients, it's about a 5-minute procedure. Very quick. And it can be done in the office with small scopes. Over the course of about 1 to 3 months, it's not instantaneous. All those proteins and dead cells get reabsorbed, and that's when the urethra opens up. So it's not instantaneous like the TERP or the green light, but long term, and the results are not quite as good in terms of the flow, but it has the benefits of being an office-based procedure and has benefits of being an office-based procedure, and it preserves that ejaculatory function better than what the TERP or the green light could do. Patients start to see improvements within about 2 weeks, but it's usually 3 months before they're feeling the full effect of it. For some people, we use it as an alternative to medications, either because the medicines aren't working or because the side effects of the medicines, they just want to come off of it. And most people are feeling pretty good. Like, if we do it on a Friday, they're back doing moderate activity, swinging a golf club by Monday. In the office, about 2 hours. It takes time to get you set up. We put numbing medicine in the urethra and let that kind of percolate for a little while. But the procedure itself is only 5 minutes. Usually send somebody home with a catheter for 1 to 3 days. And again, like I said, pretty quick return to normal activity. Oral medications about an hour before the procedure used to be just a Valium. Now we do have the option. There's kind of been a pretty cool improvement in office-based urology where we use a low dose of nitrous oxide, similar to what the dentists use, but with more safety because it's a lower dose, kind of diluted out with oxygen. And within 20 minutes of that, people are well enough that they can actually drive home. So, is it right for you? Well, again, it's not necessarily the right thing for everybody. I have patients who may come in asking for one thing, and a lot of times after these talks, we get people to show up, and I'm like, they come in for the rezum, and I'm like, your prostate is so big, or your issue, you need the laser. Just because you have a Ferrari doesn't mean that every environment is the right place for the Ferrari. And they call it the rezum because the idea is you're supposed to resume your life. That's it. Any questions?
How many times have you done the rezum?
I've only done the training. It just got FDA approved and licensed in Virginia. So I've done all the training. It's kind of a pretty, I've seen it done. It's a pretty transferable skill. You figure every day, somewhere between 5 and 10 times a day, I'm putting a scope in somebody. And instead of putting a grasper in to grab a stone or to laser a stone, I'm just punching it into the urethra. So I've done all the simulations and passed all the skills for the training, and so I'm certified to do it. But it just got approved. And it's only been in the last month or so that insurance has said they'll start to pay.
Will it remove the part that goes up into the bladder?
It can. That's why this one's the benefit that the UroLift doesn't have. The UroLift is only for the small to medium. This can go in there. And because it gets contained within the lining of the urethra and lining of the prostate, we don't have to worry about the steam dissipating out into other places. So you don't have to worry about it injuring another organ on the other side or injuring the bladder on the other side of the prostate. But it does cover the whole thing.
How large before you couldn't do this?
How long before we can
How
do it?
large is the prostate to be before you can't do this? You said it wouldn't be good for large ones?
No, no, you can do it on any size,
Okay.
but there are people who come in who may have a little kidney failure because their prostate is so big it's resulting in backup of the bladder, backup into the kidneys. And I'm like, do we really want a procedure that's going to take 3 months to see the full activity and let your kidneys potentially deteriorate over that time? And then there are other prostates where I'm like, you know, maybe this rezum is going to buy you some time, but do you want a procedure that's going to buy you time, or do you want it definitively done? I will say most of the guys that get into their 60s and 70s are potentially a little less concerned about ejaculatory function, because that's really the big thing. That's the real draw, and the fact that it's an office-based procedure. Most of the guys are not, you know, that concerned. They'd rather just have their overall health taken care of. But when, for the select patient, you can kind of cure it all with fewer side effects, it's good for that person.
How many laser procedures have you done? Many?
Today, I mean, figure I probably do of like the laser, let's say on average 1 to 4 a week for the last 15 years.
How many patients had issues percentage-wise after that?
In terms of, you know, issues, like if you're talking about when I orgasm, nothing shoots out, 50 to 90%. I mean, I would say, I mean, it's a fair number. 90% will have some at least decrease in semen, 50% may have none at all. In terms of, it's true 10% reoperation. Either the prostate's so big you just can't laser it all out in one setting. Some guys, you control them for 3 years, and you look back in, and it's like, man, new prostate tissue has grown. Or 5% stricture formation occurs. So 90% never need another surgery again, and I found that to hold true in my practice. 10% needs something done again in the future, either to get rid of scar tissue or to get rid of new growth of prostate. In terms of, with the laser, we don't see really any decline in erectile function beyond what, you know, some guy comes in when he's 65 and has the laser done, and he comes back in when he's 68 and says, my erections aren't as good. Well, take a guy who's 65, then look at him when he's 68, he's probably going to tell you his erections weren't as good anyway, whether or not he had a laser. That does not seem to be independent, or I should say dependent upon a laser procedure. So we don't see much in the way of erectile dysfunction as a result of laser. The way we did with the old-fashioned TURP, that was a good 10%, easy, right out of the box. You knew that 10% were going to come back with problems. I've given one person a blood transfusion with the laser. It's not common, as I told you. I'm doing 1 to 4 a week for 15 years, and I have had one person who needed a blood transfusion. It was a bleed that occurred after, you know, a couple of weeks after the procedure. He got a little too active a little too quickly. Urinary tract infections, anytime you instrument the urinary tract infection is possible. And the risk of the laser, the risk of the rezum, the risk of the urolift, that's all the same because it's basically all the same instrumentation. And that's about 2 to 5%.
Is rezum just new to this area, or has it been around for a while?
So a lot of times when they're testing it, you know, we think of Medicare as being like, you know, Medicare for everybody, but there are different areas of different zones of Medicare. So it was approved in Maryland and the Northeast originally, and that's where a lot of the studies were done. So it has not been done in Virginia.
How long has it been
I
around?
think it's been around for about 2 years.
2 years.
Our group, Darby, Ani, and I, we are the first certified ready to do it in Virginia, is what the rep told us. Maybe they just tell that to all the guys, but that's what they told us.
And then once those, the steam kills those cells, do those cells regenerate over time?
So those cells won't.
But new ones do.
New ones can come. So that's the one thing we talk about the durability. I don't know the long-term durability. What we do know is that that over the first 2 years of the study period, the symptom relief seems to be about as good at 2 years as it was at 6 months. So the short-term durability is there. I don't know what will occur over the course of time. And again, everybody's different. I mean, there are some people whose prostates will grow like wildfire. And like I say, even after doing the laser, I've had again, I'm doing the lasers usually for the bigger prostates. I had one guy that did a laser. I used about 4 times the amount of laser energy on him than I would for anybody else. 2 years later, I did the same thing with 4 times the amount of laser energy again. And last time I checked him, he's still doing great. But I mean, he basically had 8 times the laser of what a normal laser would be. Not even the normal prostate, just what a normal big prostate would get. And so for like him, I did end up, after the laser, I put him on a medicine to help curb the growth. There is a medicine, finasteride, that does help slow down growth of prostate tissue. I was like, look, your genetics are such that this is, we've seen what happened in a few years. We know this is going to happen again.
Which insurance plan is covering this?
So we know Medicare is. We are told that Blue Cross Blue Shield will. But, we're kind of, you never know until you put it to the test and really see. But usually once things go through Medicare, it tends to go downhill. And a lot of times, once you start looking at office procedures and instead of all the costs of hospital, then it becomes advantageous to the insurers, especially if it's going to be durable. And especially if it's not going to result in a lot of other procedures down the line. Again, I do worry about that with the urolith. I'm not entirely comfortable with having the foreign body in there. We put stitches in people all the time. Yeah, but is the prostate different? Is there going to be some reaction? And we just don't know. And I do take the mantra of, do no harm, seriously. So it's a question for me. I'm hopeful it's going to be proved, that that's not an issue, but. And people do it, and it's FDA approved, and there haven't been any long-term issues. It's just something that I have always worried about from the moment the urolift was introduced. And I was happy that but at the same time, I could see the benefits of it. Potentially done in the office, potentially quick, maintains that ejaculatory function for those guys that want it, where that is important to them. And then within a year of the urolift being out, all of a sudden we're getting all the literature, the studies being done on the rezum, and it's like, okay, well this seems more up my alley because we know how laser energy impacts the prostate. We know how microwave energy impacts the prostate. There was not an increased risk of prostate cancer with those things. There's not an increased risk of prostatitis with those things. So, we could pretty much extrapolate that data to the rezum from just a safety standpoint, and so I feel comfortable long term there, more so than I do the others.
Are there possible side effects of finasteride as bad as dutasteride? Did I say that right?
Yes and no. So there are a couple of forms of, those are called 5-alpha reductase inhibitors, and there's a couple of variants of that, and dutasteride blocks both variants, and finasteride only blocks one. So some people see a little bit of improvement with finasteride compared to dutasteride, but for the most people, they're pretty much, Coke and Pepsi, very similar products, and interchangeable with interchangeable results.
You indicated to me that if you took dutasteride and you got cancer, it would be a very bad kind of cancer, possibly.
Well, that's the cancer risk. So dutasteride and finasteride equally lower your risk of prostate cancer by 25%. But if you get prostate cancer, there's about a 2 to 3% higher likelihood that it's a more aggressive kind.
With either one.
With either one. Which is not to say that it's going to be a more aggressive kind, but it's a 2 to 3% higher risk. So you have to balance that risk reduction of 25% if you're taking that medicine versus that slightly increased risk of it being more aggressive.
Does the dutasteride actually cause a decrease in the size of the prostate? Or is it just
For some people it does, and for other people it just slows the growth. Some studies have shown, like the best I've ever seen was that there was a series of studies where it had about a 40% reduction in size of the prostate 2 years after taking dutasteride. And for other people though, it just slows the growth. Like my guy who, I've done 8 times the amount of laser energy on him, for him I just know it's going to slow the growth.
So for some people it take it forever?
It'll take forever. And again, everybody's prostate's a little bit different, and it's nice to have options. you know, and it's nice to be able, having more options, we can tailor our treatments a little bit better to try to meet everybody's need. We don't have to fit every round hole or every round peg into a square hole.
I have a question. At what age did you start getting prostate exams?
It depends on risks. So I have no risks, and my primary care doctor decided to start screening me at age 40, just figuring because he thought I would want to. You know, certainly pretty much everybody by 50, assuming they have 10 years of life expectancy. If you have 50 and you're walking around carrying an oxygen tank and you know, on your third heart attack, yeah, you probably don't even necessarily have your prostate screened. Prostate cancer is a slow-growing thing. So for screening for cancer, certainly pretty much everybody at 50, if you think they're going to live at least another 10 years, you should start looking by then. Family history, African American, 40. Notice I said African American. I didn't say black, because truthfully, it's interesting. The risks for prostate cancer in Africa, different than what they are here. Higher in America. So the genetic factors here among African Americans are higher. So you start, they have family history starting at age 40. White guy or Asian guy with a family history probably starting around age 45. And you continue it on until you don't think that person's going to live another 10 years, because in general, prostate cancer usually takes at least 10 years to kill somebody. So why go looking for a disease if you don't think they're going to be around to see the finish line of that disease and process anyway? As far as when do you screen for prostate health, pretty much you start thinking about that every time you pee. Geez, that took a long time. Why? You know, because prostate health, if in terms of how you're urinating, can progress to kidney failure, to bladder dysfunction. It's no secret that you see a lot of catheter commercials on TV now that I don't remember ever seeing when I watched TV when I was a kid. I think I watched a lot more TV when I was a kid than I do now. And yet I can't watch a football game without hearing about somebody's catheter. And that's because people are living longer, prostates are getting bigger, and also there are other medical conditions, diabetes, Parkinson's disease, that we see a lot more of that can weaken the bladder so that people can't compensate for their enlarged prostates nearly as well.
What are the signs for getting cancer? How can you tell other than BPH maybe? It just happens, or?
The signs you can tell is that your PSA is high, your rectal exam is abnormal, and you've had a positive biopsy. If you're having a symptom related to prostate cancer, it's because it's spread to your bones and you're feeling pain in your bones. If you have urinary symptoms, it's because you have likely BPH and prostate cancer. Now, I can tell you several examples of people who had horrible urinary symptoms because they had a very aggressive prostate cancer. But you figure if I'm seeing like 35 patients in my office a day and 5 of them are prostate cancer patients every day, and I can remember the 2 guys that happened to, you know, that's a very small subset. So you're not seeing disease, you're not seeing symptoms of cancer until it's out of the box, which is why there's the push for early screening. Notice none of the ladies are having any questions.
Do you have
For a
any
friend.
candidates for rezum lined up?
I do. Yeah. We're trying to bunch the first few together just for the ease of the flow in the office and so forth. But yeah. All right. Thanks for coming.
One more question.
Yeah.
Where did y'all get those cookies or scrumptious?
Oh, taste limited,
It's
unlimited.
just right across the, street there in the city center, Oyster. It's called Taste.
Taste?
Take some on your way out, there's plenty left.
They have,
After the
Yeah, they do,
became
and salads and
cottage
stuff.
industry to remove the stents,
Oh.
and you know the
And
I do
Mexico
too.
over here.
I do too. And I need to say my
so
traveling.
nobody calls you.